diabetic patient. So let me tell you what is chronic kidney disease. You know about it already. Chronic kidney disease is defined by renal impairment lasting for more than or equal to 3 months. So never use the term chronic for anything less than 3 months. And this renal impairment may be either a fall in GFR and raised creatinine, which we are all well aware of. But what we are not aware of, that we can have chronic kidney disease even without a rise in creatinine. Meaning, when you have proteinuria lasting for more than 3 months, or small kidneys or ultrasound, and renal fibrosis on biopsy. So you can have chronic kidney disease with or without a rise in creatinine. Anything more than 3 months, any abnormality in the kidney is chronic kidney disease. So how do we classify the chronic kidney disease? There are different severities of chronic kidney disease, and they are basically based on GFR. Normal GFR is more than 90. So you can have a CKD more than 90 if you have proteinuria. And the severest stage of chronic kidney disease is stage 5, where the GFR is less than 15. And this stage, you need to take the person on dialysis or transplant, and all of us as nephrologists are scared of this stage. Why we are scared? Because CKD has become a huge burden. We all know 18% of our population has diabetes, 20% have hypertension. But do you know that 17% also suffer from chronic kidney disease, which is a huge number? And how does it translate into figures? We are a population of 1.2 billion Indians. And do you know 80 lakhs of us have chronic kidney disease per year, new CKD per year, 80 lakhs. And out of this, 1 to 2 lakh have end-stage renal disease per year. So 2 lakh end-stage renal disease, out of which 50% is diabetic kidney disease. That is 1 lakh diabetic kidney disease, end-stage kidney disease per year, a huge number. You may say that we have all options available, we can dialyze the patient, we can do a transplant. So what's the problem if we have diabetic kidney disease? There are 2 problems. It is impossible to treat all patients with diabetic kidney failure because of the sheer numbers. In India, we have facilities for roughly 10,000 transplants per year. We do roughly around 50,000 dialysis per year. So per year, we are able to treat just 60,000 patients. And every year, we have 2 lakh new patients added to this population. So 2 lakh every year, and we have facilities only for 60,000. So it is very clear that we cannot take care of the end stage of chronic kidney disease or end stage of diabetic kidney disease. The other problem is the cost of CKD treatment. Look at the cost. Transplant is 5 lakhs for a transplant with immunosuppression of 10,000 per month. And dialysis is 30,000 per month. So you can imagine the cost. And average Indian income is just 2,000 per year. So you can see the large disparity between the expenditure and what's the cost, income. And a person obviously cannot afford. Can the government afford? No. Our budget is just 2.5% of the total budget is spent for health. And in India, problem before any government, be it Modi government or any other government, is sheer numbers, multiplying population and dwindling budget. Thus, it's very clear neither the patient on his own or the government can afford the treatment of chronic kidney disease, and prevention is the only answer. And how do we prevent it? We prevent the major cause of chronic kidney disease, that is diabetic nephropathy. 1/3 of all patients with diabetes progress to nephropathy. And that is why in our country, diabetic kidney disease is become the commonest cause of end-stage renal disease. What is diabetic kidney disease or diabetic nephropathy? It's nothing but kidney disease occurring in a diabetic, characterized by a gradual progression with development of hypertension, proteinuria, and falling GFR. So it's a gradual disease most of the times. And it progresses to certain stages. It doesn't happen overnight. Initially, there is stage of hyperfiltration, the stage 1. Stage 2 is latent, when nothing is abnormal. Patient is fine, physician is fine, kidneys look fine. The third stage is stage of microalbuminuria, when small amounts of protein start appearing in the urine. The fourth stage is massive proteinuria, when it becomes nephrotic syndrome. And the last stage is dialysis dependence. High creatinine, high urea, you need dialysis. So there are 5 stages, very clearly defined in type 1, less clearly defined in type 2. And you can see that for initial period, the patient is comfortable, physician is comfortable, diabetes is under control, may or may not be under control, but there is a slow decline in GFR and there is appearance of proteinuria. The features of diabetic nephropathy are the kidney disease generally starts 5 years after the onset of diabetes generally. There is heavy proteinuria. There is no hematuria in clear-cut case of diabetic nephropathy. Gradually progresses with a fall of 10 ml per minute per year. Normal fall of GFR in non-diabetic is 1 ml per minute per year. This is 10 times the fall in GFR. And 50% or above can have retinopathy. So this is the natural history. Now why does diabetes cause nephropathy? It's a complicated slide, but my aim to show it here is there are three main mechanisms. First thing in yellow is the effect of glycemia, and you can see a number of molecules there. Formation of AGEs, advanced glycation products, protein kinase C pathway, polyol pathway. So this I am talking about because the newer treatments which target these pathways. Then blue figure shows hypertension. So the second major progressor is hypertension, and it acts through renin-angiotensin system. The third important thing is the effect of obesity and metabolic syndrome. So these are the three major pathways, and finally they lead to diabetic fibrosis and death of the kidney. So all the pathways finally cause inflammation and death of the kidney cells. That's how diabetes causes diabetic kidney disease, by effect of hyperglycemia, hypertension and metabolic factors. Does genetics have a role? It does. Which genes, which chromosomes? There are multiple candidate genes, multiple chromosomes, which itself shows that no single gene has been identified so far. There have been some studies on ACE gene polymorphism, but that also is not that conclusive. If your parents have diabetic nephropathy, both of them, you have 45% risk of developing diabetic nephropathy yourself. So genetics does have a role. Now when should we suspect CKD in diabetics? The problem is it is missed because it has varied manifestations. It can present in the late stages with azotemia, uremia, vomiting, decreased appetite. It can present with fluid overload, swelling. So these are easy to pick up. Your diabetic patient has these problems, he has developed diabetic kidney disease. This we all can understand, we all know. But the problem is it can sometimes present with anemia because kidney produces erythropoietin. So in your diabetic patients, if anemia is resistant to treatment, think of nephropathy. It can present with bone disease because kidney activates the vitamin D. It can present with hypertension because kidney is responsible for BP control. So diabetic kidney disease is missed because it has varied manifestations, and we should be aware of all these manifestations. The most important point is diabetic kidney disease in a diabetic may be totally asymptomatic, no symptoms, urine is normal, no swelling, nothing, and these are missed. The only thing abnormal would be some tests, the appearance of micro amounts of protein in urine. Otherwise the individual is symptomatic unless it's picked up. So you can see on the left side of red line, no symptoms. The early stages, stage 1, 2, 3, where GFR is slowly falling, there is microalbuminuria. Right side you have symptoms. In India we pick up most of the patients on the right side. But our aim is to pick up the patients on the left side where there are no symptoms. And two tests what we need to do to pick up the early stages are, you can understand that you have to look at the microproteinuria and the GFR. So urine albumin creatinine ratio and GFR are the two tests which should be done by all physicians in all diabetics at least once a year. In type 2, you should screen from the onset. In type 1, you can wait for 5 years before you start screening for kidney disease. Urine albumin, we know that normal urine albumin is less than 30 mg per day or less than 20 microgram per minute. Microalbuminuria, now called moderately increased proteinuria, is 30 to 300 mg per day and 20 to 200 microgram per minute. And you should test for micral, small simple test is available, cheap also, in the absence of infection, pregnancy, ketosis, CHF and exercise. And 2 out of 3 readings should be taken over 6 months. So single reading is not important, you have to follow it up. So first screening test is microalbumin. Second test is to do a GFR. Looks complicated, but it is not. You can ask the lab to give the GFR, most of the labs are giving, or otherwise you can use a calculator which is available online. You just have to Google it, write MDRD GFR calculator and put creatinine there. You can download it in your cell phone. So this is very easy. So microalbuminuria and GFR. So these are the first two tests. Now, if the GFR comes less than 60, then you have to do the other kidney failure tests, which you all know: electrolytes, uric acid, workup for anemia, mineral bone disease, calcium, phosphorus, vitamin D, PTH, ultrasound for kidneys, and other systemic examinations. So these are done if the GFR is less than 60. When do we do a kidney biopsy? Kidney is involved in a diabetic patient. Should we do biopsy for everybody? Biopsy is the gold standard? No. For clear-cut diabetic nephropathy, biopsy is not needed. We do biopsy when there are certain clues. For example, as I said, if there is no retinopathy, a typical diabetic generally has retinopathy. Absence of retinopathy may be an indication for biopsy. If urine shows hematuria, you have to do a biopsy. If there is skin rash, which does not occur in diabetic nephropathy, you have to do a biopsy. And if the progression is atypical, that is rapid rise of protein, suddenly within 5 years the proteinuria has become nephrotic range, or rapid fall in GFR. So biopsy, these are the indications for biopsy in a diabetic. And these patients should be referred to the nephrologist whenever these things are there in your patient. So causes of these problems: non-diabetic kidney disease, renal artery stenosis, some glomerular diseases, infections like pyelonephritis, emphysematous pyelonephritis, papillary necrosis, radiocontrast, etc. So these are non-diabetic kidney diseases. Here diabetes is not causing the kidney problem, these things are causing the problem, and you have to treat it. Therefore remember that 25% of patients of diabetes can have these diseases, and be on the lookout for these. Now how do we manage it once we have diagnosed it? So I have labeled them as the 7 sacred commandments, or the 7 sacred vows of marriage. Easy to remember. So hyperglycemia, hypertension, lipid control, diet and lifestyle, prevention of acute insults, further insults, and some others, and renal replacement therapy. Now hyperglycemia management, let us have a quick look. So glycemic control is very, very important. It can prevent the diabetic nephropathy in up to 30%. And many of the trials have shown that in type 1 as well as type 2 diabetes. So they retard the progression from normal albumin to microalbumin. They also prevent microalbumin from going to the nephrotic syndrome stage. Glycemic control may not be that useful in the last stage, but for early management, glycemic control is very, very important. And the target, what should we target? 7. Less than 7 is not indicated for diabetic kidney disease for fear of hypoglycemia. So the core word is not too tight, just right. Then how do we treat? How is it different? Is it like a normal diabetic? Two things are different. First thing is, in the initial stage when the patient is developing hyperglycemia in nephropathy, because of the uremic toxins, there is resistance to insulin, and that is why you have increased insulin requirements. Hyperglycemia may be seen. But later on, as the renal function GFR go down, the insulin levels go up in the blood. It's not excreted by the kidney. So you have hypoglycemia. So initial hyperglycemia, late is hypoglycemia. And other cause of hypoglycemia is most of the older drugs are excreted through the kidney. So their levels go up and you have hypoglycemia. Thus, remember, recurrent hypoglycemia in a diabetic who was alright till now should indicate that he is having development of diabetic nephropathy. Sometimes it's the first sign of diabetic nephropathy. Now, how do we treat this hyperglycemia? All available insulins can be used. You have to adjust the dose. Insulin as well as analogs, both are safe. You have to just titrate according to the levels of sugar. What about OHAs? Are all of them banned? I said they are excreted to the kidney, so should we use none of them or all of them? So let us look at these. Metformin is a wonder drug and remains a wonder drug in diabetic nephropathy. Initially there were some concerns, but now the right way to use it is you can use it safely as long as the GFR is above 30. But be careful, monitor the renal functions more frequently. So less than 30, it is contraindicated. What about sulfonylureas? Forget about all sulfonylureas except glycoside and glycoside. They are safe. They are used in all stages of diabetic kidney disease, even in a patient on dialysis. What about the other drugs? What about the metaglimenides? Avoid them in severe diabetic nephropathy. Early stages they may be used. What about pioglitazone and rosi? Should not be used. They are not excreted through the kidneys. Then they should be safe, but they are not used because of the fear of fluid retention. So glitazone's consensus is not to use. Then what about the carbos and oligos? Severe stages, avoid. What about gliptins? They are good drugs. They can be used even till the last stages of chronic kidney disease, and there are studies which show that they may prevent the progression of chronic kidney disease. Then what about the incretin mimetics? These are also not used in severe stages. So the bottom line is insulin, glipizide, glycoside and gliptin. These 4 drugs are safe in all stages of renal failure. Second important thing is hypertension. And what should be the target? New guidelines have made it easy, 140 by 90 all. That's what JNC 8 says. But other guidelines are still conservative. They say that if proteinuria is there, maintain it a little bit less, 130-80. If the patient is able to tolerate 130-80, you are able to achieve 130-80, maintain 130-80. Now which drug? So any drug can be used as long as you are able to control the blood pressure. Now, having said that, most important drugs are ACE inhibitors and ARBs because they have pleomorphic effects beyond BP control. Do we give ACE inhibitors and ARBs for all diabetics? No, they are not used for primary prevention. You should give ACE inhibitors or ARBs if there is either proteinuria, microalbuminuria or hypertension. So they are not given without proteinuria or hypertension. That's what the consensus is. Now which ACE, which ARB? Some studies have shown ACE is better in type 1, ARB better in type 2, but there is no consensus guidelines. Any of them can be used. And which of them? Many of the studies are with ramipril, losartan and telmisartan, but as a consensus guideline, nothing to choose. Now combination, if we add up both of them, would that be good? So previous trials showed that you should add them, and there were many studies, come, cooperate, they said add them, but now consensus is the combining of these two is a bad idea. You have falling GFR, you have increasing potassium, and after on target, this combination of drugs is a definite no-no. What about statins? So all diabetic nephropathy patients should receive statins. All diabetic nephropathy patients. However, statins are not used on dialysis. So they are not started de novo on dialysis. But those patients who are continuing to have diabetic nephropathy on statins, go for dialysis, you can still continue them. Now, fibrates and statin combination generally is not recommended in CKD patients, and all statins need dose modification except atorvastatin. So these are few points, key points about statins. Diet and lifestyle, we all know, energy 35 kilocalorie per kg, avoid fried items, go from white to brown, more brown in your life. Salt 1 teaspoon per day if normotension, 2 gram, that is half teaspoon if hypertension. And take care of the 3 P's. What are the 3 P's? Protein, potassium and phosphorus. Restrict all of them. Protein normal 1 gram per kg per day. In diabetic it's 0.8 gram per kg per day. Diabetic kidney disease 0.8 gram per kg per day. High biological value, vegetable protein is better. And soy protein is a good vegetable protein. Potassium, avoid juices, avoid coconut water, fruits which are safe, papaya, apples can be given. And phosphorus, avoid coke, milk products. So avoid or restrict the 3 P's. Modify lifestyle. So apart from exercise, which everybody knows, cut down sedentary time less than 2 hours. No to smoking. Avoid acute insults. So you can see that the diabetic disease progresses to end stage over 25 years gradually. But if acute factors are there, it can progress rapidly to end stage kidney disease. And what are these acute insults? Drugs, nephrotoxic drugs, any obstruction. Some stone has developed in a diabetic patient can be missed. Any infection, dehydration or uncontrolled blood pressure. So remember these 5 insults, they are in your hands. A creatinine of 2 may jump to 12. And you may think that patient has reached end stage, but that may not be the case, and these are the factors which have caused an acute rise, the 5 factors. The drugs, I would like to dwell for 1 minute. Nephrotoxic drugs are very important cause of progressive renal dysfunction. Avoid painkillers, herbal medicines, and unnecessary contrast studies. CT angios should be done only if mandatory. Other things are taking care of anemia, looking at bone disease, and vaccinations in diabetic. They hold true for patients with diabetic nephropathy as well. Hepatitis B, pneumococcal, influenza, varicella should be given. The last thing is renal replacement therapy. If you have failed, a patient has progressed, hemodialysis, PD or a transplant. All 3 modalities are possible in a diabetic. Some newer drugs are available. This already was discussed. SGLT2 inhibitors, which are safe in diabetic nephropathy, can be used. These are the newer drugs. Busy slide, I already showed you the slide. Just I want to show that so many drugs are available which can block the various pathways. Eliskerin, the fibrosis inhibitors, the age product inhibitors. But as so many drugs are there, you can very well understand that none of them is of proven benefit. So last 3 slides on our own data. This is our center. We do a lot of diabetic dialysis. We do 2,500 dialysis per month, out of which 1,500 is diabetic dialysis. These are our transplant patients. We have done 500 living kidney transplants. Many of them are for diabetic patients. We have also recently started cadaver transplants, and diabetic patients form a good number here also. And our conclusions are CKD due to DKD is underdiagnosed and undertreated. We are unable to manage the increasing load. So summing up, ladies and gentlemen, my key points would be diabetic nephropathy is definitely an important cause of chronic kidney disease. Treatment, as I showed you, is very costly, unaffordable for India. Prevention is the best option, and that we can do by early diagnosis. We should not miss the early part, and that is done by albumin and GFR. Renal biopsy only if you suspect non-diabetic kidney disease, and after that, once you come to a diagnosis of diabetic nephropathy, follow the 7 sacred vows. So these are the 7 sacred vows which I already highlighted. So ladies and gentlemen, I thank you for a very patient hearing.